Welcome to the online weight loss surgery information session for Coastal Carolina Bariatrics. Hello, my name is Dr. Michael Logan Rawlins, and I am the Bariatric Surgery Medical Director at Summerville Medical Center. I have been practicing surgery since 2012, and I'm a fellowship trained minimally invasive and bariatric surgeon. I'm also board certified by the American Board of Surgery. I'm also a proud military veteran with 14 years of active duty service in the United States Air Force, and I'm very grateful to be in a town with such a strong military heritage. Our program is conveniently located at Summerville Medical Center, which is a part of Trident Health. Most of the services you will need for the bariatric surgery program are located on the main campus of Summerville, including our medical office building, radiology, EKG, lab, the operating room, the endoscopy suite, emergency room care. The only things that you may need to go off-site for are consultant services such as cardiology, sleep study, and psychology. During this session, we are going to talk about obesity and how it impacts your health and life, why you should consider bariatric surgery, who is a candidate for weight loss surgery, what are the different types and the risks of surgery, what are the pre-surgery requirements and the next steps in order to get surgery, and then why you should choose Coastal Carolina Bariatrics. So we know that obesity is a major health problem in the United States of America, especially in the Southeast. About 2/3 of the adults in the United States are considered overweight or obese, and about 500,000 people die every single year from medical complications related to their weight. And currently, only about 1% of people who are eligible for bariatric surgery nationwide actually receive it. So the big question we have to ask ourselves is, why is that? What are the factors driving why so few people are seeking out this option for care? We do know that obesity is a chronic disease process, and even the American Medical Association has come out and said that it is a disease. We know that it has multiple causes, including genetics and your environment, but also diet, exercise, and psychological stressors do play an important role as well. We know obesity is a lifelong process that will be with you forever, that's progressive and will get worse over time, and that it is life-threatening and can kill you. And for a long time, there's been a stigma in treating obesity. But really, we should treat obesity just the same as we treat other medical illnesses, such as heart disease, joint disease, and cancer. The goal of weight loss surgery is not only to alleviate weight, but also to help resolve some of these obesity-related health conditions that we know can cause early mortality in people. Conditions we're specifically targeting are ones like sleep apnea, heart disease, high blood pressure, reflux, joint disease, diabetes is a big one, non-alcoholic fatty liver disease, which is now becoming the most common cause of cirrhosis in the United States, and high cholesterol, which can also contribute to heart disease. We often use a term called the BMI or the body mass index as a way to understand where people are on the weight spectrum. Where we start getting worried about people is in the BMI class of 30 to 35, which is when people start developing medical problems related to obesity. But once you get into the category of BMI of 35 to 40 and 40 and above, those are the people that are considered morbidly obese that are going to benefit the most from weight loss surgery. We know that diet and exercise is the cornerstone to all weight loss. And most people who are seeking weight loss surgery have tried many diets and exercise programs and just not been successful. Because the average weight loss is very modest, and a lot of times the weight that is lost is commonly regained. And we do know that studies have shown that when people are morbidly obese and their BMI is over 35 or 40 or even higher, that their chance of successfully losing weight with diet and exercise alone is very, very low. And they just get fed up and frustrated and kind of give up. And it's like climbing up like a really steep hill that you just really can't get up because you just need that jump start or that reset to kind of help you over the edge. And that's really where surgery comes into play. Is it's really that extra push that's going to kind of get you over the hurdle in addition to doing the diet and exercise. When we look at what the benefits of surgery are, we know that surgery in multiple studies has been shown to be the only treatment that can provide substantial and durable long-term weight loss, meaning that you can lose a large volume of weight and keep it off for long periods of time. Things that you can't really do with diet, exercise, and medications alone. We know that surgery will eventually lead to fewer medical problems, less prescription medications, overall better mobility, increased life expectancy, a better quality of life, and a decreased cancer risk. Many patients ask, how is this surgery going to help me lose weight? How does this surgery work? Well, it works by three primary mechanisms. The first is restriction. So every diet you've ever been on before in your life takes advantage of restriction. If you take in less calories than your body's able to burn, you will lose weight. So all of the surgeries work to limit the size of your stomach, to limit the amount of calories that you can intake. Secondly, some of the operations, such as the gastric bypass and duodenal switch, involve an intestinal rearrangement so that you don't absorb as many of the nutrients that you are eating. That's the malabsorptive effect. And then lastly, there's a hormonal effect where removing part of the stomach or bypassing part of the stomach or bypassing part of the small bowel can lead to a change in gut hormones, which decreases your hunger and the signals that are in charge of metabolism and storing food. I also get asked by many patients about when they should consider surgery. And I always tell people that weight loss surgery is never the first step in the process. You should always try diet and exercise therapy first. But if you can't lose weight with that, you don't want to wait until your weight becomes such a huge problem that you've developed really bad medical issues related to your weight. So you don't want to wait until you get, quote, too big or your medical problems worsen too much, where you've got horrible heart disease, really bad diabetes, joints that don't work anymore. And you certainly don't want to wait until you're in a wheelchair and you can't walk anymore. So I always tell people it's not the first step, but it's not the last step. It's somewhere in the middle. And that certainly once you meet criteria for surgery, weight loss criteria, with a BMI of over 35, that you should strongly consider whether weight loss surgery is an option for you. Many patients also ask, well, how much weight can I expect to lose with surgery? Well, we use a term called the percent excess weight loss. And that is the percent of the excess weight you are over normal body weight that we expect you to lose within 1 year after surgery. Okay, so how do we calculate that? Well, if we take a 5'3" female, the ideal body weight at a BMI of 25 is 140 pounds. If that woman actually weighed 240 pounds, she would be considered 100 pounds overweight. And if she lost 70 of that 100 pounds, that would be a 70% excess weight loss. And that is what we consider to be the average weight loss in a successful surgery, 70%. Now, most people who have weight loss surgery are going to lose somewhere in the 50 to 80% range, depending on exactly which surgery they had and how well they did with the diet and the exercise. But if you can maintain that weight loss down the road and maintain at least 50% of the excess weight you've lost, that's considered to be a successful surgery. We are now going to move on to talk about the two most common bariatric operations that are currently done in the United States. That would be the sleeve gastrectomy and the gastric bypass. In the next slide, we will show you an animation of how a sleeve gastrectomy is performed. All bariatric operations, including the sleeve gastrectomy, start with the placement of 5 small portholes on the abdomen through which little instruments and cameras will go. Once inside the abdomen, the stomach is identified. This is a normal appearing stomach, which can typically hold about 2 liters worth of solid food or liquid. Next, once the stomach is fully mobilized, a stapling device is utilized to divide the stomach, and the excess stomach is then removed. The remainder of the stomach left behind resembles a small skinny banana through which your food will travel. There is no intestinal rearrangement of the bowel. This maintains a normal anatomic continuity of digestion.
The advantage of a sleeve gastrectomy is that it is a stomach-only operation where we remove 80% of the extra stomach you do not need, but there is no intestinal rerouting with this operation. Therefore, it typically leads to a shorter operating room time, which is good for patients that have existing medical problems where we should get them off the OR table quicker. It also provides more revision options for down the road if we would ever need to convert it to a gastric bypass or a duodenal switch for patients that develop reflux or have medical problems that did not resolve with the initial operation or did not lose enough weight with the initial operation. The main disadvantage with a sleeve is that we can see an increase in the amount of reflux that patients have after the surgery, whether they had reflux before or not. And compared to the gastric bypass and duodenal switch, the sleeve tends to lead to a little bit less weight loss.
We are now going to review the gastric bypass anatomy. In this operation, the stomach is divided to make a small proximal gastric pouch about the size of an egg or two. In contrast to the sleeve gastrectomy, no stomach is actually removed during this operation. The stomach is only divided. After the stomach pouch has been created, the small bowel is then run and divided downstream. The small bowel is then brought up to drain the gastric pouch that was created, creating the small intestinal rearrangement. Here you see the completed gastric bypass anatomy. The blue area is where the food comes down through the pouch into the roux limb. The yellow area is where all the digestive juices are from the stomach and the pancreas and the bile ducts. And the green area is where the digestive juices meet up with the food to perform digestion. The gastric bypass is considered the gold standard bariatric operation. It has been around for the longest period of time, and as other operations have come and gone, it has stood the test of time. We know it is a very effective operation for treating diabetes and for very bad reflux disease. It also has an added side effect called dumping syndrome that aids sweet eaters in controlling their cravings. When the patient eats simple sugars, they will get a flu-like illness that will remind them that they should not eat that anymore. Some of the disadvantages of a gastric bypass are that it has a longer operating room time, so you're on the OR table longer, which puts you at higher risk of perioperative complications. There also is a very real risk of vitamin and nutrient deficiency after gastric bypass, so it's very important to make sure you eat your adequate protein intake and take your postoperative vitamins. Some of the lifetime risk we worry about after gastric bypass include marginal ulcer, which is an ulcer you can find at the connection of the small bowel to the stomach pouch, and also small bowel obstruction, more likely than not from an internal hernia from where we rearrange the bowel, but can also be seen due to an intussusception where the bowel telescopes on itself. For the reason of marginal ulcers, patients can no longer use NSAIDs ever again after a gastric bypass because these can contribute to ulcers, in addition to smoking, which is also prohibited for your lifetime after a gastric bypass. As we wind down our discussion of the bariatric operations, I did also want to mention the duodenal switch. This operation is not as commonly performed as the sleeve and the gastric bypass, as it is a little bit more complex and only performed by a limited number of surgeons that are comfortable with its anatomy. The advantages of a duodenal switch are that it provides the best weight loss of all the operations. It's also the most effective for diabetes. And it also has less dumping than the gastric bypass because of an intact pylorus. We also see less ulcers than a gastric bypass because of the small bowel to small bowel anastomosis, as opposed to the stomach to small bowel as seen in the gastric bypass. The disadvantages of a duodenal switch are that it also has a long operating time like a gastric bypass, and it has the highest risk of vitamin and nutrient deficiency, which is why it is very important to take your vitamins, eat adequate protein, and have very good follow-up to make sure there are no complications that are developing. There's also another variant of this operation called a one anastomosis duodenal switch, or a SADI, where only one anastomosis is created as opposed to two down at the lower part of the small bowel. The duodenal switch is kind of like a combination of a sleeve and a gastric bypass in the fact that a sleeve is done on the stomach and then a small bowel bypass is performed, but it is connected to the duodenum and not to the stomach, and the amount of bowel bypassed is more significant than the gastric bypass. Patients will often ask me, well, what surgery is right for me? Is it the sleeve or the bypass or the switch? And I always tell them, well, this is a joint decision-making process with your surgeon, but ultimately you have to be comfortable with the decision that you make for your body and understand the risks and benefits of each of the operations. I will say that the weight loss with the switch and the bypass is definitely a little bit better than a sleeve. However, when you look at the risk of long-term complications, the opposite is true. The sleeve has the lower risk of long-term problems compared to the switch and the bypass. Now, the switch and the bypass are also much better for reflux, diabetes, and metabolic disease, but the sleeve, on the other hand, is better for patients that are at extremes of age, that are much younger or much older. It also has a quicker OR time, which carries less perioperative risk, and it has many more revision options for down the road, as it can be converted to both a gastric bypass or a duodenal switch. Our center also performs revision surgery and conversion surgery. In revision surgery, we are operating to fix a problem with a previous operation. This is most commonly seen in gastric bypass operations, where patients can develop a marginal ulcer, which can bleed, perforate, or obstruct. They can develop a stricture or a narrowing of one of their anastomoses. They could develop a fistula between their pouch and their old stomach. They could develop an internal hernia from a small intestine rearrangement or an intussusception from the small intestine rearrangement. People can also develop worsening reflux and a hiatal hernia after massive weight loss, or they can develop pouch or anastomosis dilation, which may require revision of that anastomosis or pouch. There's also the possibility that an inadequate amount of bowel may have been bypassed with the gastric bypass in order to aid in postoperative weight loss. And if this is the case, the bowel length can be lengthened. In contrast to revision surgery, in conversion surgery, we are actually converting one bariatric operation to a different bariatric operation. This is commonly done for poor weight loss, weight regain, or possibly complications. The common types of conversion surgeries that we do would be converting a sleeve for a planned second stage procedure to a duodenal switch for patients who had a very high BMI before their sleeve. We also will convert lap bands to sleeves or bypasses. We will convert sleeves to gastric bypass for bad reflux, or we will convert sleeves to a duodenal switch for failed weight loss or metabolic disease. Our program does also offer medical weight loss drugs. These are certainly a good second-line therapy after surgery if there is any weight regain that has occurred. And this can add additional weight loss after the operation. It can also be used without surgery, prior to surgery, or as a standalone therapy. However, sometimes there are insurance coverage issues. There are many different pill and injectable options, especially with the new class of GLP-1 medications, which can be very effective in weight loss rescue. We are now going to talk a little bit about complications after bariatric surgery. We will start talking about some early temporary effects. When we make your stomach small and or rearrange your bowel, it is very common to have a lot of taste changes and nausea, and this can lead to poor fluid intake, which can then lead to dehydration. It is not entirely unusual for patients to need to go to an infusion center or to the emergency room to get additional IV fluids if they become dehydrated. It's also very common to see hair loss after surgery as people are starting to lose weight rapidly. This is a normal occurrence. There are also some more serious complications related to weight loss surgery. The one we worry the most about are staple line leaks. So the staples that we use for the surgery are just there to hold the tissue together until the body naturally heals it on its own. But if it doesn't, you can develop a hole anywhere along that suture line or staple line, and that can be a major complication that could land you in the hospital for weeks or months, potentially need additional operations or IV nutrition or a feeding tube, and can take a few months to heal. Blood clots can form in your lower extremities from lack of movement, and if they do and they mobilize to your lungs, that's called a pulmonary embolus, and that can kill you. Marginal ulcers we talked about before are common in people using NSAIDs and that are smoking, so you're not allowed to do that ever again after a gastric bypass operation, as ulcers can be very problematic because they can bleed or perforate or obstruct. Bleeding can happen from any bariatric operation since we are dividing with staples, using suture lines, and dividing blood vessels. Infections can be in the form of pneumonia lung infection, urinary tract infection. Any of your incisions could get infected. You could get an abscess in your belly. You can get a diarrhea called C. diff colitis diarrhea or a yeast infection. Internal hernias are seen after small bowel intestinal bypass operations, such as the gastric bypass or duodenal switch, because when we rearrange the intestines, we create a space behind the intestines that we close with suture. However, as you lose weight rapidly, those spaces can open back up again, and bowel can slide in there and get stuck and cause a bowel obstruction. Now, the risk of any of these is overall fairly low, but these are definitely more significant complications that we worry about after bariatric surgery. Now, although there are known complications related to any surgery, and including bariatric surgery, there is a myth out there that bariatric surgery is not safe. The reality and the truth is that bariatric surgery is very safe. In fact, when you look at the outcomes of bariatric surgery versus, say, taking your gallbladder out, your uterus out, or your appendix out, they are very similar. And bariatric surgery has actually been proven to be safer than colon surgery, joint replacement surgery, and heart surgery. It is also important to note that bariatric surgery 20, 30 years ago was not very standardized and was not performed by surgeons that did that as a routine part of their practice. Whereas today, there are a number of standards which must be met in order to be able to perform bariatric surgery at centers of excellence, and that has increased the safety of these types of operations. Keeping in line with the theme of safe surgery, all bariatric surgeries these days are now being done laparoscopic and or robotically. The advantages of doing these surgeries compared to open surgery include fewer wound complications, less bleeding, decreased infections, fewer hernias, less abdominal pain and faster recovery, better surgeon visualization, much more precise, accurate suturing, and wristed instrumentation. I am often asked by people when we do robotic surgery, is the robot doing the surgery? And I always tell people, as you can see in this picture here, that the robot is docked to the ports that I insert the instruments through, and then the surgeon sits at a console and controls all the instruments. So the surgeon is in control of all of the instruments during the case. The robot is just aiding the surgeon in doing the surgery by being much more precise. Next, we are going to talk about some additional surgery considerations. The first is that patients are not allowed to smoke around the time of surgery, and so all patients who are previous smokers must stop at least 2 months before surgery and at least 2 months afterwards. And if you are having a gastric bypass, you can no longer ever smoke again because it can lead to the formation of ulcers. Also, with gastric bypass, you are not allowed to use NSAIDs or ibuprofen or naproxen containing compounds because these can also cause ulcers. A lot of patients will ask about body contouring after weight loss and when they can do this. We usually wait at least 12 to 18 months when you have lost the maximal amount of weight, And if you have excess skin hanging off and you have recurrent infections or discomfort due to that skin, it can be excised. We typically do not recommend that people consider any pregnancies within the first 18 months following surgery because we do not want you trying to grow a fetus while you are trying to actively lose weight, as this can sabotage your weight loss. Typical hospital stay after surgery is about 1 to 2 nights. Most of our patients typically will stay about 1 night, but occasionally a patient may stay a second one. People are returning back to work or school within 2 to 4 weeks, especially if they have a sedentary desk job. They can go back within 2 weeks. If they have a manual labor heavy lifting job, sometimes it takes as much as 4 weeks. Patients are also required to take lifelong vitamin supplements. Some operations, such as the bypass and the switch, have a little bit more requirements, but these will be your responsibility to purchase, and you must be taken for the rest of your life. Follow-up is also very, very important after these operations. We see you back after surgery at 2 weeks, 4 weeks, 3 months, 6 months, 12 months, and then every year after that, and sometimes more frequently if you're having any issues or problems. You will often hear me constantly talk about the 4 pillars of effective obesity management, which include surgery, diet, exercise, and eating behaviors. And each of these things individually is not going to help you lose the weight or keep it off long term, but all of them acting synergistically together for the rest of your life can make you very successful. Now I'm going to get on my soapbox for just a minute. I always tell people that you have to realize that surgery is very helpful and it will force you to lose weight in the first 6 to 12 months, but it is only a tool and it will not last forever. It is not a magic bullet forever. You should consider surgery to be your jump start or your reset button to get you down to where you want to be. But ultimately, the long-term success you have is going to depend on your adherence to good habits that you develop in the post-operative period, such as good diet, good exercise, and good eating behaviors. And weight regain is possible if you do not follow the diet, exercise, and behavior modification. I sometimes see patients in clinic who are seeking a revision from a previous weight loss operation who have weight regain. And when I see them, they tell me, the surgery didn't work for me. And then I ask them, what does that mean? And they said, well, I lost 150 pounds, but then I gained it all back again. And what that tells me is that the surgery did work for you. The surgery did its job. Its job is to force you to lose that 150 pounds in the first 12 months after surgery. But the surgery's job is not to keep the weight off long term. What's going to do that is good diet, exercise, and eating behaviors. And if you don't follow that, weight regain is possible. As part of the weight loss surgery program, both before and after, the diet is a very important part. Every time you come to see us before surgery, you will see a dietitian and get weighed in. And we will talk to you about some of the changes that you can make prior to surgery to be more successful afterwards. We do expect that people are going to try to put some of these changes into play. And typically, if you do, we will see a little bit of weight loss prior to surgery. We want to identify what those changes are that you can make. And we want to instill in people the change mindset that I can do this prior to surgery and not that you're just waiting until afterwards to make some of these dietary changes. We also do not allow any weight gain in the surgery workup process. We don't require weight loss, but if you do make some small changes, you will lose some weight. But if you're gaining 10, 15, 20 pounds in the workup process, that clearly means that we're not making the changes we need to make in order to be successful. Some of the changes that we're focusing on before surgery are that you're really trying to get good sources of lean protein and vegetables in your diet. And while we also do not prohibit carbohydrates, we want to limit them as much as possible. Ideally, we just want a good, healthy, balanced diet. You can see this plate to the right where you see that protein should be about half your plate, and then the carbs should be about a third of the other half, and then vegetables or salad should be about 2/3 of the other half. We encourage people to use small plates and measure their portion sizes. Ideally, we're shooting for about a quarter to a half of a cup of food per meal. You can see in these measuring cups down below, you have a quarter of a cup, a third of a cup, a half a cup, and a cup. So you can really kind of see an idea about how much a quarter to a half a cup of food is. And we encourage people to even measure their food out ahead of time and also after surgery. We want you to avoid grazing. We want you to eat 3 to 4 small meals per day and not graze in between. We want to avoid high calorie foods and liquids, things that are not good for you, milkshakes, sweet tea, etc. We want you to slow down while you're eating. Chew every bite about 20 times. Put your fork down after every bite, or even use chopsticks. This will force you to eat slower. You always want to eat until you're satisfied, not until you're full or stuffed. You have to learn that feeling. Hydrate. You need to hydrate yourself. You need to drink at least 64 ounces of fluid daily to stay hydrated. This is going to be very important after surgery, as it's very possible to become dehydrated if you're not drinking enough. We will do a liquid protein diet 1 week before surgery and then also 2 weeks after surgery. We also harp a lot on personal accountability. This is your surgery. This is not my surgery. I don't live at home with you. And that when you go home, I'm giving you the tools to help you be successful, but ultimately you have to make these choices for yourself in order to be successful with the surgery. And you should set goals for yourself and hold yourself to those goals and have personal accountability. Exercise is also very, very important, just as much as diet is. It's a vital component of weight management. If you do not exercise after surgery, you will not be as successful as someone that does diet and exercise. So we ask you to start slow and early. We want you to try to get a pedometer or a fitness app or start an exercise log and challenge yourself. You really want to do any activity that's going to get your heart rate up and that's going to get you sweating, at least 30 to 60 minutes a day. Set measurable goals for yourself and hold yourself to those goals. But you must move after surgery or you will not be as successful. So what do you need to do in order to get to surgery? Well, the initial process starts with meeting the surgeon for an initial consult. We will also meet with the dietitian to talk about your dietary habits. We will check your BMI requirements to make sure you meet criteria and also call your insurance company to verify you have bariatric benefits. We will then start you on a 3 to 6 month physician supervised diet, which is required by insurance. In each visit, you will have nutrition evaluation. We'll get fasting blood tests to check for other medical problems and to make sure you don't have any pre-existing vitamin deficiencies. We will make sure that you're not smoking or encourage you to stop. We will get all other required testing and clearances so that you can proceed forward with surgery. Sometimes that includes a cardiology evaluation or a sleep study. We will also perform an upper endoscopy where we take a look down your esophagus and stomach to check to make sure you don't have any really bad reflux disease or hiatal hernias or tumors or masses or ulcers. I do all those procedures myself in the operating room, so we will get you scheduled for that as well. You also have to have a mental health evaluation, which is a requirement through the insurance company and also through the ASMBS for our credentialing. This is to make sure you don't have any undiagnosed or untreated mental health disorders that could be a barrier to you being successful with the surgery, and that you understand the life changes that you need to make in order to be successful. And then finally, once the surgical workup process is done, we will get insurance approval from your insurance company and then book a surgery date. And lastly, we want you to know why you should choose Coastal Carolina Bariatric Surgery for your operation. We are a comprehensive bariatric center that provides both medical and surgical weight loss support and also dietary support that is not always found in every program. We are an ASMBS Center of Excellence program, which demonstrates our dedication to our patients and to a culture of quality and safety. Dr. Rawlins is board certified in the practice of surgery and is fellowship trained in minimally invasive and bariatric surgery. So you know that your surgeon has the top qualifications to perform these operations. Dr. Rawlins also has extensive experience and has been in practice for over a decade. He has very low complication rates and great patient outcomes. We also want you to know that you can have surgery close to home in the heart of the Low Country. For patients that live in and around the Summerville area, they don't have to travel into downtown or across too many bridges. They can have surgery close to their home with ease of access. And lastly, we want you to know that we care about your weight loss journey. There are some programs that think that weight loss surgery is just an operation. And Dr. Rawlins does not see it that way. Dr. Rawlins feels that the surgery is just one piece of the puzzle, and that we need to be there for you both before surgery to prepare you properly and after surgery to follow through and make sure that you are doing well. And so we are there for you every step of the way, and we care about your results long term. So let's get started. We're very excited to see you in our office for a new patient bariatric surgery evaluation. You can call the number below for a self-referral.